This lecture is intended for undergraduate students, and today's topic is approach to a patient who presents with a stroke or TIA. Let's start with a scenario. A 64 years old male, known case of diabetes mellitus and hypertension presented to emergency room with sudden weakness of right side of his body. What is the diagnosis? If you have already reached a diagnosis, well and good. Otherwise, you can pause and think about it. The diagnosis here is most probably a stroke. Now, we will look in this scenario what are the features that direct us towards the diagnosis of stroke. First of all, there is a focal neurological deficit that is sudden in onset. Along with that, this patient has diabetes mellitus and hypertension. His age is 64 years and he is male. So, focal neurological deficit that develops suddenly, and the patient who has the risk factors for development of stroke like diabetes mellitus, hypertension, old age, and male sex. So these are all the features that direct us towards the diagnosis of stroke. So what is stroke by definition? Stroke is sudden onset focal neurological deficit that lasts for more than 24 hours and is vascular in origin. So if a patient fulfills these criteria, he is most probably suffering from stroke. Another important definition is transient ischemic attack. It is similar to the stroke except that the deficit lasts for less than 24 hours. The only difference between stroke and transient ischemic attack is time. If it lasts for less than 24 hours, it is TIA, otherwise it is labeled as stroke. Let's talk about the burden of this disease on the society. Stroke is the leading cause of disability worldwide and the third most common cause of death after cancer and ischemic heart disease. The prevalence of stroke in Pakistan is about 1.54 per thousand people. The alarming situation over here is that the incidence and prevalence of stroke is on the rise. It is basically because of unhealthy and sedentary lifestyle along with increasing life expectancy and increase in the incidence and prevalence of diabetes in Asiatic population. So we have seen in the scenario that the patient has sudden onset focal neurological deficit and then he has the risk factors for the development of stroke. So what are the risk factors? If they are present, we can say that this patient is at risk of having stroke. These risk factors are divided mainly into two types. Those who can be modified are called modifiable and those who are non-modifiable. Modifiable risk factors include diabetes mellitus, hypertension, hyperlipidemia, smoke, excess alcohol consumption, oral contraceptive pills, sedentary lifestyle. These are the diseases that or conditions that predispose to the stroke but can be modified to prevent a stroke. Then there are non-modifiable conditions like age, gender, male are more prone to have stroke than females, race, Afro-Caribbean more than Asians and Asians more than Europeans. Then there are previous vascular events like myocardial infarction, peripheral vascular disease, peripheral embolism. These are all the conditions that are non-modifiable but are risk factors for the stroke. Stroke is mainly divided into two types. One is ischemic, that is because of the blockage of the blood vessels. It is the commoner cause among the two. 85% of the patients of stroke are of ischemic. Then there is second type that is hemorrhagic stroke. It is present in 15% of patients of stroke in which there is not the blockage but explosion of the blood vessel that leads to the compromise of the blood supply. Here we can see an ischemic area because of the blockage of the blood vessel, and here it is hemorrhagic because of the leak of the blood into the brain tissue. Let's start with ischemic stroke. As we have discussed that ischemic stroke is the commoner of the two and it is because of the occlusion of the blood vessels. And there are basically two etiologies that lead to the ischemic stroke. Either it is a thrombus that arises from the blood vessel and go up to the brain to block the vessel, or it is an emboli that can arise either from heart or from peripheral vessels. When we talk about the etiology of ischemic stroke, then we have discussed that there is thrombotic or emboli. Thrombus can be large vessel thrombus or thrombus can arise because of hypercoagulable disorder. Then there is embolic. Emboli can arise from heart which is the most common source of emboli in conditions like atrial fibrillation, myocardial infarction, mural thrombus, bacterial endocarditis, and valvular conditions. And one very important is paradoxical embolus. We say a paradoxical embolus when an emboli does not arise in heart but in peripheral vasculature, and normally it should go into the lungs. But because of atrial septal defect or ventricular septal defect, this comes into the left-sided circulation and can reach brain. This is called paradoxical embolus. And then there is artery to artery emboli, like at the carotid bifurcation or aortic arch. Here, etiology of ischemic stroke, we can see that emboli can arise because of atrial fibrillation and or any other arrhythmic heart disease, valvular diseases, thrombus in the left ventricle. This emboli can rise from the heart and go into the brain circulation. And where it is going to be lodged depends upon the size of emboli. If it is a big embolus, it can block a large blood vessel, or if this is a small emboli, then this will block a smaller blood vessel. Then there are thrombus, which is at the carotid bifurcation. So pathophysiology of ischemic stroke. What happens is that when either thrombus or emboli blocks a blood vessel, then the blood supply to that part of the brain is disrupted. So this leads to the ischemia. When ischemia develops, it depends upon how much is the blockage. If there is no blood flow, the brain tissue can die within 4 to 10 minutes. And if it is less than 16 to 18 milliliter per 100 gram of tissue per minute, then infarction can occur within an hour. So what happens is that when blood vessel is blocked, ischemia develops. And then there is a tissue in the center which is directly involved by the blockage, and this tissue becomes necrosed and dead. This is called core. This is the core of the infarct. And then there is an area around the core that is not infarcted yet, but it is at the risk of becoming infarcted and can convert into core. So this is called penumbra. It is very, very important that you understand the concept of core of the infarct and penumbra around it, because as the time passes by, core becomes big and penumbra starts to shrink. So that's why when you see a CT scan of a patient of stroke after 24 hours, you see a very, very big infarct. It is because blockage was not reversed and the core has reached to the maximal size, and penumbra that could have been saved was not saved. So that is from where the term time is brain comes. That if a patient comes to an emergency with ischemic infarct, you have to act quickly, very quickly, to unblock this vessel. This is done by using two techniques. Either you can thrombolize the blockage, you can break away in little segments and clear the blockage, or we can go mechanically upwards at the place of blockage and we can remove this thrombus. So it is important to understand that time is brain. If you do not act quickly, you are going to lose the brain tissue. So when a patient comes, treatment of choice is TPA. So this is what we have discussed, that ischemic penumbra, in the beginning there is a large tissue that is at risk, but as the time passes by, core starts to increase. Here we can see that this is core, this is a blockage, this is the core, and this is penumbra. This is all the tissue that is at risk. So as the time will pass by, core will start to increase and penumbra will decrease. And the primary goal of the treatment is to save this penumbra, because core is already dead and we cannot save it, but we can save penumbra. So this is the objective of the treatment of stroke now. There was an era when a patient with stroke would come and we will do nothing and we will wait for the nature to take its course, for the collaterals to develop, but now this has changed. The second type of stroke is hemorrhagic stroke. Hemorrhage into the brain can be divided into two categories, like intracerebral bleed, ICH, and subarachnoid hemorrhage. The other difference from ischemic stroke is that hemorrhagic stroke has a higher mortality when compared with ischemic stroke. It is up to 3 to 4 times more dangerous than ischemic stroke. Now, intracerebral hemorrhage is a result of chronic hypertension. Because of chronic hypertension, the blood vessels, they become stiff. They cannot relax normally, so they start to leak. And when suddenly there is a rise in blood pressure, they cannot expand and leakage starts into the brain tissue. There are other causes other than hypertension. There are amyloid angiopathy, anticoagulant therapy, cavernous hemangiomas, and especially if a young patient presents with a stroke, don't forget to ask about the drug abuse like cocaine and amphetamine. Subarachnoid hemorrhage. Subarachnoid hemorrhage is the second type in which the hemorrhage occurs in subarachnoid space, and the most common cause of subarachnoid hemorrhage is aneurysm, rupture of aneurysm, and the other cause is AV malformation. This usually presents in the form of severe headache. The patient will present in emergency or OPD with a headache and will tell you that this is a worst headache that he has in his life, also called thunderstorm headache. How a patient of stroke will present, we have already discussed. If we know from definition as sudden onset focal neurological deficit. So when you start taking history, you focus on two things. Is it sudden in onset and is there any focal neurological deficit? If patient has a neurological deficit and it is not sudden in origin, it can never be stroke. Or it can be stroke in evolution but not for final year purpose. But if a patient presents with a disease that is sudden in onset but you cannot find any focal neurological deficit, again it cannot be a stroke. Is it in vascular in origin or not? This usually can be determined on investigations. Other important point that you need to discuss or take history are the risk factors. Either patient has previous TIA or MRS Fugax because these are the patients who are at risk of having recurrent CVA. Any history of hypertension, diabetes mellitus, all the risk factors that we have discussed, modifiable or non-modifiable risk factors, you have to take into consideration. Then any history of seizures and migraine because there are some conditions that are not stroke but they are stroke mimics and you have to treat them differently, not as stroke. So it is very important that if a patient has a history of seizures and migraine and these patients can have stroke, but most probably you need to rule out these things before thinking of stroke. Any history of anticoagulation therapy, history of oral contraceptive use, hypercoagulable disorders, polycythemia vera, and in young patients, abuse of substances, drugs like cocaine and amphetamine. Examination of the stroke patient. When a patient presents to you, the examination can be very difficult because the neurological findings will depend upon the location of the infarct or bleed. They vary greatly. Other features or other conditions that predispose to the stroke, you can look for them like on skin, you can look for xanthelasmas, in eye, you can look for diabetic and hypertensive changes. In cardiology, you can look for hypo or hypertension, abnormal rhythm, murmurs, JVP raised, any bruit in respiratory system, any pulmonary edema, infection, abdomen, urinary retention. These are the complications that can arise because of stroke. In locomotor system, any injuries sustained during collapse due to stroke or any comorbidities that will affect the prognosis of the stroke. So clinically, we classify stroke into TIA, progressing or evolving stroke and completed stroke. Now, it is important to discuss the stroke syndromes that you can see. We have discussed that on examination. There are variable findings depending upon the location of the stroke. So it is important that you remember some stroke syndromes that if a patient presents these features or clinical signs, then you need to think about the stroke. So we have discussed during the previous slides that clinical examination is variable of stroke patient. It depends highly on where is the blockage or where is the bleed and will depend upon the location of the stroke. So it is basically divided into large vessel stroke with interior circulation or posterior circulation, and then there is small vessel disease. Here, circle of Willis, we can see the division between interior circulation and posterior circulation. In posterior circulation, two vertebral arteries they join to form the basilar artery, and which supplies the posterior part of the brain. And then there is anterior circulation in which internal carotid artery supplies and give rise to the middle cerebral artery and anterior cerebral artery. These arteries supply the anterior part of the brain, and then they are communicating through communicating arteries. So, stroke within the anterior circulation. The internal carotid artery and its branches, they comprise the anterior circulation of brain. That is anterior cerebral artery and middle cerebral artery. So let's start with the middle cerebral artery. As you might have known that middle cerebral artery supplies the anterolateral part of the brain. So the symptoms are these areas of the brain like paralysis of contralateral face, arm, leg and sensory disturbance in the same area. Otherwise there can be aphasia which can be motor, sensory or conduction aphasia. It can also give rise to homonymous hemianopia and paralysis of the conjugate gaze to the opposite side. Apraxia, it is agnosia plus apraxia. So apraxia is a loss of ability to execute or carry out learned movements, and agnosia is loss of knowledge. So the objects normally that you can recognize, they become unrecognizable. And apraxia, the movements or the things that you were able to do, you had learned how to do them, you forget them how to do. Then comes the anterior cerebral artery occlusion. If the stroke occurs in the anterior cerebral artery, there is paralysis of the contralateral foot and leg. If you remember the homunculus, you may remember that foot and leg area is on the medial surface of brain. So when there is occlusion of anterior cerebral artery, there is paralysis of the contralateral foot and leg, sensory loss in the contralateral foot and leg. Then there is transcortical aphasia, gait apraxia, and urinary incontinence, which occurs only when there is bilateral damage in the acute phase. So as we have discussed that if thrombus goes into the internal carotid artery at the origin of MCA or into the MCA, then we will find the symptoms of MCA infarct, and sometimes it leads to the massive infarct of the entire deep white matter and cortical surfaces. This is called malignant infarct. So when the origin of both anterior cerebral artery and middle cerebral artery are blocked, what we will see, that we will see hemiplegia, hemianesthesia along with stupor and coma. One very important point, that internal carotid artery do not only give branches like middle cerebral artery and anterior cerebral artery, it also gives branches like ophthalmic artery. If ophthalmic artery is blocked, then we can see amaurosis fugax, that is transient, or it can be permanent. Patient typically presents with horizontal shade that sweeps down or up across the field of vision. When internal carotid artery is blocked, we can hear a bruit that is called carotid bruit, but as the stenosis progresses, the bruit may disappear. Infarct of the posterior circulation will give rise to dysarthria, facial numbness, ataxia, Horner's syndrome, facial weakness, hemiparesis, hemisensory loss, hemianopia, loss of consciousness, diplopia, vertigo, and vomiting. Clinical presentation depending upon it is thrombotic or embolic or hemorrhagic. These are just to help you, but they do not usually present in this way or not always present in this way. In thrombotic, there is history of TIA, stroke in evolution, and it usually happens early in the morning. Embolic, it happens in patients with known heart disease, because emboli, it arises either from the arteries or from heart. So the patient is usually a known case of ischemic heart disease, and so depending upon the size, usually the recovery is rapid. Hemorrhagic stroke usually happens in the patient who has positive history of hypertension, and they usually present with headache and vomiting. Differential diagnosis. If a patient presents to you with stroke, there are stroke mimics, as we have discussed previously. These are the signs and symptoms that will point towards the diagnosis of stroke, but still these can be other things like hypoglycemia, seizures, migraine, subdural hematoma, and SOL. Of these, SOL is less likely to present as stroke because the progression is over longer period of time. But sometimes it can present as a stroke if there is bleed inside SOL. So let's discuss them one by one. Hypoglycemia may produce symptoms that resemble stroke like hemiplegia and aphasia along with confusion, but every patient who presents to you in emergency or in your clinic, please check his RBS. Seizures and post-ictal state is another very important differential. Seizure can present with paralysis or paresis of limb called Todd's paresis. So how you can differentiate between seizures and stroke? Usually patients of seizures have previous history either they are taking anti-epileptic drugs or they have previous history of epilepsy. Another very important differential is migraine. Migraines can actually bring upon a stroke, but sometimes patients with migraine have symptoms and signs that are similar to a stroke. This is the one of the biggest cause of error in stroke centers, where stroke physicians inject TPA to the patients of migraine. So how you can differentiate that is it a migraine or a stroke? Similarly, as we have seen in seizures that they have history, and in migraine, there usually are known cases of migraine. They have previous episodes of migraine, and if a patient presents to you for the first time and you are not sure that is it a migraine or a stroke, what you will do? There is very little evidence, but in my opinion, it is better to give TPA to a patient of migraine than not giving TPA to a patient of stroke. But still, there is no clear evidence. So, make an effort to rule out migraine before labeling a patient CVA. As well, they are usually slow growing and there is no acute presentation, but sometimes they present as bleeding into the tumor. To summarize, as is in the definition, rapid onset focal neurological deficit is stroke, and where the deficit is will decide upon the site of the lesion. Management of stroke. If a patient presents to you and you are suspecting stroke, how you are going to manage? First of all, there are emergency investigations and then there are follow-up investigations. The objective of investigation is to confirm the vascular nature. Up till this point, we have confirmed that there is sudden onset focal neurological deficit, and now we are going to confirm our third criteria, that is vascular inner region. So the objective of investigation is to confirm the vascular nature of the lesion, and if it is a vascular, what type of vascular lesion it is, and then the underlying vascular disease and the risk factors. The first investigation of choice in a patient of stroke or suspected stroke is always a CT scan. Here we have a list of investigations that can be done in patient of stroke, but first investigation is always CT scan. Here they are divided into non-invasive and invasive like CT scan, MRI, MR angiography, PET, SPEC, Doppler ultrasound, and invasive LP, CT angiography or contrast angiography. These are the investigations that are not necessarily done in every patient of stroke. There are some patients who are candidate of these investigations. So you select these investigations depending upon the underlying etiology. CT scan, as we have discussed, is the investigation of choice. Why? Because our first objective is to rule out hemorrhage, and CT scan is best in ruling out hemorrhage. It appears at a hyperdense area, while infarct is a hypodense area. So the main objective of CT scan is to rule out hemorrhage, because infarct can take time to develop, but hemorrhage is immediate. Other advantages of CT scan is that it is readily available, it is less costly, and it takes less time. Here are some examples. Here we can see right-sided thalamic hemorrhage. Here is another example of hemorrhage. We can see that these are hyperdense lesions. Now ischemic lesions, we can see hypodense areas with massive shift of midline. Here is another example of hypodense area. So if a patient presents to you stroke or you suspect stroke, the first investigation is CT scan. Vascular nature is confirmed, that either it is hemorrhagic or ischemic. Now you can manage the patient, treat the patient, and then you can search for the source. So we have learned that ischemic stroke can be thrombotic or embolic. If it is thrombotic, it will arise from the vessels. If it is embolic, it can arise from either heart or arteries. And then there are hemorrhagic CVA, and then we need to find the etiology of hemorrhagic CVA, what is going on. So these are the investigations that can be done, and you select these investigations from patient to patient, not all in every patient. This is an example of carotid ultrasound. Here a probe is placed on the carotid artery and we see for any blockage or any disturbance, plaque, hemodynamic instability. These are the things that we see on carotid ultrasound to look for a source of either thrombus or embolism. Here, this is an example of carotid ultrasound. There is complete blockage of carotid artery. An example of digital subtraction angiography. Here we can see right common carotid artery is stenosed. This is a 3D angiography where we can see stenosis at carotid bifurcation. An example of AV malformation and a large aneurysm. Then there are some cases in which CT scan is normal, but you clinically suspect that this might be a hemorrhage, like subarachnoid hemorrhage, which sometimes does not show up on CT scan. So the next investigation in line is lumbar puncture. You do a lumbar puncture and look for xanthochromia. If xanthochromia is positive, hemorrhage is confirmed. Xanthochromia is a degradation product of RBCs. Then comes a late investigation in which we try to find out underlying diseases like cardiovascular diseases, in which we will like to find if there is an MI, atrial fibrillation, other kind of arrhythmias, valvular heart disease. The investigations are standard like ECG, echocardiography, heart monitoring, blood culture if we suspect infective endocarditis. Other risk factors like serum lipids profile for hyperlipidemia, ENA for SLE, if we suspect arterial dissection, MR angiography, lupus anticoagulant for antiphospholipid body syndrome, PTA, PTT, platelet count for bleeding disorders, protein C and S for hypercoagulable state. Treatment objectives. As we have discussed previously, that the objective of treatment is to minimize the core of the infarct in infarctive tissue and save the penumbra. So actually what we are doing is we are minimizing the volume of brain that is lost. Second objective is that if we have saved or unable to save that brain tissue, we prevent complications. Then rehabilitation so that patient can go back home and live normally, and then reduce the risk of recurrence. Let's start with the treatment. We will start with the treatment of TIA. Remember from the definition that focal neurological deficit of vascular in a region that lasts for less than 24 hours. So if a patient of TIA comes, we need to find out the underlying cause and do the secondary prevention so that this TIA does not recur or do not go towards the stroke. TIA actually are a warning signs that something big is coming or can come, so stop it if you can. So the steps that can be taken are medical management or surgical management, like stop smoking, and the concurrent medical problems like if there is atrial fibrillation or if there is underlying hypercoagulable state or if patient is suffering from SLE, any vasculitis. This is the time to treat these conditions. If patient has diabetes mellitus, hypertension, hyperlipidemia, treat these conditions. So if the cause is found to be an arterial stenosis, so what are our options? If this stenosis is mild or moderate, we can do a regular follow-up. Or if this stenosis is severe, like in case of carotid artery, if it is between 69 to 99%, then we can do carotid artery. Now the management of stroke. If a patient presents with an acute episode of stroke, the steps are basically the same. Every patient who presents in emergency should be processed in the same way: airway, breathing, circulation. But in stroke patient, note that airway is the most important point. Other than taking medications or treating the acute episode, the most important point is maintaining the airway, because this is the second most common cause of death in stroke patients after stroke, because patients do aspirate and this aspiration pneumonia worsens the prognosis considerably. And in our culture in Pakistan, where families are very touchy and they try to give him something to eat or to drink. This goes directly into the respiration and cause aspiration. Patients with stroke and aspiration pneumonia have considerably poor prognosis. So every patient of stroke who comes in emergency, please do NPO for 24 hours to prevent aspiration and maintain airway. Then breathing, oxygen saturation 97%. If a patient does not have underlying pathology or he has not aspirated or she has not aspirated, usually you do not need to give an oxygen, but the objective is to maintain at around about 97%. Circulation. If you are not giving patient adequately by mouth, then patient is going into hypovolemia. So to maintain the blood pressure and circulation, you can give fluids. And if patient is not maintaining blood pressure, you can give inotropes or antiarrhythmics, whatever is appropriate according to the condition of the patient. Hydration. Then nutrition supplement. They are not needed immediately in first 24 hours, but in longer terms, better nutrition leads to better outcome. And then medications. Try to administer medications while patient is in hospital, IV other than oral. Blood pressure management. That is another very important point. In stroke patient, blood pressure management is different in infarctive stroke or and in hemorrhagic stroke. In ischemic stroke, there is auto-regulation of the brain that is going on, and brain is trying to supply maximum blood to the brain. So we should not try to lower blood pressure abruptly or very low. Normally, blood pressure should be maintained at around 180-110 millimeter of mercury. But if a patient presents with the hemorrhage, now our priority is completely different. We should lower the blood pressure. The recommendations say that the blood pressure should be lowered within 1 hour of presentation and keep mean arterial pressure of less than 115 millimeter of mercury. This is the single most important prognostic factor in hemorrhagic stroke. In my practice, the second most important point is aspiration pneumonia. If a patient with small hemorrhage do not aspirate, then the chances of survival are good. Although there will be residual deficit, but patient will survive. But if a patient with hemorrhagic CVA aspirates, the chances of survival diminish considerably. Glucose monitoring. If a patient is diabetic and he is having hyperglycemia, there is no need to go for a very tight glycemic control. Glycemic control should be very loose, not very loose, but loose, and you can maintain the blood glucose level around 200 millimeter. Maintain the blood glucose level around 200 milligram percent. Temperature, use of antipyretics, pressure areas. To prevent the pressure sores, the second most common cause of infection in patient or pressure areas. So to prevent the pressure areas, we can use ripple sheets. So the early management of stroke. As we have discussed, time is brain. As the time goes by, core increases and penumbra decreases, the viable tissue decreases and the dead tissue increases. So we need to act rapidly. Here, act fast. This is a poster for the awareness of the public that if there is facial weakness, arm weakness, difficulties in speech, it is time to call emergency services or present to emergency department. So the first treatment of choice is revascularization by either thrombolysis or mechanical thrombectomy. So we give a drug called TPA altiplase. The ideal time period should be less than 1 hour. That is called golden hour. Door to needle time should be less than 1 hour. But TPA can be given up to 4.5 hours and in selective cases up to 6 hours. The second approach is thrombectomy. In this approach, we put a catheter and goes up to the brain where there is occlusion and we mechanically remove this occlusion to relieve the obstruction. These are the latest treatment options for the stroke. Antiplatelet therapy. If you have given a patient TPA, please stop antiplatelet therapy for 24 hours. Otherwise, if patient is not in the time window, or you want to start antiplatelet therapy, then you can give aspirin 300 milligrams single dose immediately. Then aspirin can continue for up to 14 to 21 days, and then you can switch to clopidogrel 75 milligram daily. But for TIA or minor stroke, the treatment is different. You have to give dual antiplatelets like aspirin and clopidogrel for up to 90 days. So there is a difference of treatment between TIA and stroke. In TIA, you can give combination dual antiplatelets for up to 90 days. And in stroke, you can give aspirin for the first 14 days or 21 days and then switch to clopidogrel. Hemorrhagic stroke. As we have discussed, the main stay of hemorrhagic stroke management is control of blood pressure. The blood pressure should be lowered within first hour. And if there is a large volume of blood that needs to be removed, then there can be surgical decompression. And if we can find any etiology, we can do CT angiography or MRA, and we can, if we find aneurysms or AV malformations, then we can surgically remove these. One very important point: antiplatelets and anticoagulants are contraindicated. Any patient who presents with stroke, a hyperdense lesion on CT scan, do not give antiplatelets and anticoagulants. Rehabilitation. This is a very important point, and in this regard we are lacking behind in Pakistan. There is no rehabilitation centers. So the rehabilitation centers are designed to rehabilitate the patient so they can go back home and live individually without a lot of disability. So initially there is a passive physiotherapy, then later stages active physiotherapy is done. Occupational therapy is another approach. Speech therapy for the patient who have dysphagia. These are the approaches that will improve the quality of life. A stroke unit. Admission to the stroke unit of stroke patient is an independent indicator of prognosis of stroke patients. Admission in stroke units lead to a better prognosis. Why? Because the staff over there, they are better trained. They deal these patients on day-to-day basis, and the units are designed specifically for these patients. So every patient who presents with a stroke must be admitted in a stroke unit. This improves the neurological outcome and reduces mortality and morbidity. Now comes the secondary prevention. Secondary prevention is aimed at preventing the risk factors. Now we have discussed what are the risk factors, that there are modifiable risk factors and non-modifiable risk factors. Non-modifiable risk factors we cannot do anything, but there are modifiable risk factors which can be managed, like blood pressure control, diabetes management, lipid management, smoking cessation, alcohol, weight reduction. If patient has sedentary lifestyle, then moving to a physical activity, and carotid and artery intervention. So these are all secondary prevention measures which are modified or used according to the need of the patient. Then there are complications of stroke. There are immediate complications or residual complications or later complications. No. Immediate complication: patient can have seizure or cerebral edema because of the infarction or hemorrhage. Then there are residual defect from the stroke like paralysis, aphasia. And then there are later complications. These are basically because of immobility. Patient has recurrent infections, pressure sores, painful shoulders, UTI, depression and anxiety. Prognosis. Prognosis of ischemic stroke is better than hemorrhagic stroke. Mortality in first 30 days is 18 to 12%, but it depends upon the size of the infarct, condition of the patient, and then the complication that arise during the treatment. Hemorrhagic stroke has mortality of up to 50%,